So I think I've given this talk many times, and I think many of you have heard me give this talk many times. And various bits have been much better covered already, particularly the bowel and bladder stuff by our nurses yesterday. So we might get through this quite quickly. But at the same time, feel free to interrupt if needs be. Now, I was asked first to start with the different forms of ALD as much as I can. So Stefan next door alluded to this a little bit. So all the forms of ALD are caused by mutations in the ABCD1 gene on the X chromosome. But that one mutation can actually lead to all sorts of different clinical outcomes. And it turns out that one mutation in the same family can lead to different clinical outcomes in different people. So the gene codes for a protein, and that protein is a protein we find in the membrane of peroxisomes in cells. Okay, so what are peroxisomes? Well, cells are basically like a little city. They've got a wall around the outside of them, which is the membrane, and inside there are factories for energy. There's information centers, which would be the nucleus where all the DNA is that has the information for the cell. There are recycling centers, which would be the lysosomes. The mitochondria make the energy. The peroxisomes are quite closely related to the mitochondria, and one of the things they do is take these very long-chain fatty acids and break them down into other things that can then be used to generate energy and things. And the protein here is involved in getting those very long-chain fatty acids into the peroxisome, into that little center, that little factory in the cell to work. So the gene codes for a protein, and we know what that protein does. And if it isn't working properly, the very long-chain fatty acids build up in the cells and spill out into the blood, and you can measure them in the blood. So that's why we measure the very long-chain fatty acids in the blood. And that might tell us a little bit more about the disease actually than the mutation does, in that there probably is more of a link between the levels of the different very long-chain fatty acids in the blood and whether you're going to get either adrenal disease or brain disease at all. But for whatever reason, there's that problem, and the battery has now run out on here, never mind. That problem in the peroxisome can lead to a number of different problems in the body. And there are a number of different tissues involved. So at the bottom here, that's a picture of an adrenal gland. They're tiny little things that sit above your kidneys at the back. And they're important in producing a number of steroids in the body, so stress steroids, the steroids that you produce when you're unwell that make your immune system work better, amongst other steroids. And if those don't work, then you can be well most of the time, but then suddenly, if you get unwell and you need more of these stress steroids and your body's not making them, you can get very, very, very unwell. That's often how boys, and some men as well, present with adrenal failure. So it can affect the adrenal glands, but then it also affects the nervous system. And the nervous system we can split up very crudely into the brain at the top, the spinal cord, which goes down from the brain to the bottom of your spine. The brain is where all the neuronal bodies are. Well, not all of them, but a lot of the thinking and things goes on. The spinal cord, if you like, is part of that wiring system we've been hearing about in the leukodystrophies that takes the information elsewhere. And then from the spinal cord, you go out into the nerves, and the nerves go out into the limbs and take the messages both for moving muscles, but also for sensation and things. And the brain and the spinal cord and the nerves can be affected differently. So in the brain disease is where we see the cerebral adrenoleukodystrophy. And that can happen mostly in boys sort of between the ages of 5 and 10, 11, but can happen at any age. And that's the leukodystrophy. That affects the white matter of the brain, so we know that the white matter is supposed to look black. And in this condition, it suddenly starts looking white, and that's because it's suddenly got very inflamed. And the myelin is affected, comes off, and I think this is a single patient showing that it progresses with time, untreated. So that's the cerebral adrenoleukodystrophy. Yep.
Is that with contrast? Or is that
No, that's not got contrast. Or you can't see the contrast.
That contrast made when they inject?
So what the contrast, you would then look at a different scheme, a different sequence. So you've heard about T1 and T2 sequences, and I'm not a neuroradiologist, so I'm not going to get into that. But they would look at a sequence actually where all the white matter still looks black. But the contrast then would outline this. So you'd see a white line outlining this area. And that's the inflammation front, if you like, and that would gradually move outwards. So if you put contrast in and you can actually then light this up or draw around it, and what contrast is, it leaks out of the blood vessels. So normally you won't see it because it's flowing around, but if it leaks out of the blood vessels, it's there for long enough for you to see it in the MRI machine. And that's what tells you then that this is an active process rather than quiescent. And it certainly can sometimes turn off of its own accord. So I'm not showing you that here, no. I mean, there might be contrast, but you're not seeing it because you can't see it because it's behind the white. So that's what we see in the brain, and that's completely independent of what we then see in the spinal cord and the nerves, which is actually much more predictable. So in most men and many women, over time, they will develop disease that affects the spinal cord and the nerves, but not directly the brain. And that's what leads to what we used to call adrenomyeloneuropathy, but they're trying to, it's more myeloneuropathy now, spinal cord involvement, because lots of patients don't have adrenal disease, so it doesn't always go together. And that's affecting both the transmission of signals from your motor neurons in your brain to the muscles in the legs, and also affecting the nerves that go to the pelvis, the bladder and the bowel, and we heard about that yesterday, and the nerves that go to the muscles and the skin and the legs. So the muscles is what causes the weakness and stiffness of the muscles, and the nerves is what causes the sensory problems, so not being able to feel your feet, being more likely to damage them if you're cutting your nails or walking on hot stuff and things, so having to be careful. So those are the two different sorts of neurologic involvement, and then there's the adrenal involvement. Those aren't the only things that are involved. It affects the hair follicles in everybody except Chris. So we can't even predict that. But losing your hair, as I'm sure lots of people will know, is also an early feature, and we don't really understand that at all. Okay, so any questions about that bit? I guess we'll revisit that at the end when we talk about treatments. Oops. Okay, so how do we manage this? How do we look after patients with adrenoleukodystrophy? And these are guidelines that were published a number of years ago now, but are probably a good starting point for looking at how we think we should be doing it. So this is a large group of clinicians, pediatricians, adult physicians from all over the world who Mark Engelin got together in order to try and come up with some consensus, some agreement in how we manage the diagnosis and management of patients, all patients, in fact, with adrenoleukodystrophy, but we'll concentrate on the sort of the myeloneuropathy side of things, the spinal cord and the nerve side of things to start off with. And the first thing is that, unfortunately, treatment is supportive. So what does that mean? That means we can't actually, at the moment, do anything that modifies the disease itself. We can't do gene therapy for this and go in and correct the gene in all the cells in the spinal cord. And we can't actually, we've had ways in the past of reducing the very long-chain fatty acids, so that's what Lorenzo's oil used to do, or still does. If you take Lorenzo's oil and follow a strict diet, you can actually normalize the levels of very long-chain fatty acids in the blood. But unfortunately, certainly for the spinal cord disease and neuropathy, that doesn't really seem to have much effect, because it's what's going on in the nerves that matters. So the treatment's supportive, meaning we can treat symptoms, we can try and make those better, but we can't, unfortunately, at the moment, affect the underlying progression of the disease. But there's lots of drugs and other things we can do to make other things better. So let's start off with the spasticity. So spasticity is stiffness and weakness of the muscles that's in a particular pattern. It tends to affect the muscles that extend your leg more than the muscles that flex it. So you're all right if you're up and straight, but as soon as you start bending, it gets a bit weaker. And that's due to disease in the spinal cord and the muscle, the messages, if you like, not getting through properly from the brain to the muscles. So the clinical features are, well, the first thing we see is brisk reflexes. So when you go and see your clinician, certainly if you go and see me, we'll bash your knees and things, and they get very brisk. And that, in the end, goes into what we call clonus, which is when your doctor pulls up on your foot and it goes bang, bang, bang and feels very uncomfortable. And that can happen anytime. So those sort of spasms are all to do with excess activity, if you like, in the pathway, the neural pathway, the brain that's telling the muscles to contract when they shouldn't be contracting. And that can be very uncomfortable, muscle spasms. The spasms keep going, we call them dystonia, abnormal contraction of the muscles. And that leads to the characteristic gait, not being able to swing your leg out because you can't bend your leg and things. And eventually weakness means that you can't actually stay up anyway. So the aims, and spasticity occurs in a lot of different diseases. It isn't this. It's a very prominent feature of multiple sclerosis, for example. So actually there are lots of neurologists who look after spasticity and specialize in treating spasticity. I am not one of them because I'm not a neurologist. But we fortunately have lots of them in the hospital where I work, and they're looking at trying to make people more comfortable for a start, so antispasmodic medication to try and relieve that spasm and discomfort. Improving posture and trying to get people sitting, standing, and walking better. And then as time goes on, making sure that if you're in wheelchairs and things, that we're looking after pressure points and things, and preventing complications such as pressure ulcers. So there are a number of drugs they can use for that. They're the same drugs that have been around for a long time, really. So baclofen is a muscle relaxant. It's given orally, relatively well tolerated. There are some side effects, particularly at the beginning. You can get a bit drowsy. It's worth sticking with that because normally after a few days, any ghost, that'll wear off. But there are some other side effects as well. And you don't want to stop it suddenly, because if you stop it suddenly, you can get very stiff all of a sudden. So when we withdraw it for any reason, we'll do that slowly. But on the whole, it's well tolerated. Sometimes we just use a little bit at night for people who are getting spasms at night. Sometimes we use it during the day as well. But the main side effect is that as you get rid of the stiffness, you uncover weakness. So if we get rid of the stiffness, and the stiffness is what was allowing you to stay up and move around, then actually that may adversely affect your mobility. Tizanidine is also a drug that reduces stiffness. It's probably got rather more side effects than baclofen, so it's a sort of second-line treatment, but we can use that as well. And these are dantrolene. I don't think we really use very much in the UK anymore. But gabapentin we probably use more. So gabapentin is a drug that was developed for neuropathic pain as an anti-epileptic agent as well. And it can also help with spasticity, and particularly if that spasticity is associated with pain. Also has side effects. It's another one that can make you feel very drowsy, so we tend to build the dose up slowly. Whenever you read you get drugs, you'll get a white leaflet inside which tells you all the side effects. And normally the first thing people go in and do is read that, don't. Because he'll tell you absolutely everything under the sun. But if something does change for you, don't tell your doctor, and they can tell you whether they think it's actually related to the drug or not. So those are sort of oral treatments aimed at reducing the stiffness in the muscle. There are also some injectable treatments now, and botulinum toxin is what we'd be using mostly, and that actually acts here. So botulinum toxin stops those nerves from giving signals to the muscles to tell them to contract. So actually it paralyzes the muscles, which is what you use it for in cosmetics, is paralyzing those muscles, getting rid of wrinkles and things. And used properly in spasticity, it can be quite useful. It blocks the message that goes from the nerve to the muscle to tell it to contract. It's reversible, so it does that for a set amount of time, several months, but then it'll reverse. But over time, it becomes unreversible. And it can be used, for instance, to relax gastrocnemius here, so that you can actually no longer get your foot flat again rather than it being down. And that can be quite useful. And then finally, that's baclofen being given by injection directly into the muscle. You can also give baclofen by a pump. So this is baclofen being given by a pump into the spinal cord. That's a specialist treatment. It's experimental to some extent, but has been quite useful. And then there are non-drug interventions, stretching and splinting, exercise, and exercise we think is very important to keep going, and then functional electrical stimulation. Have I got some slides on that? Yep. So this is something that, again, can be useful in the early effects of the disease. So when the problem being that if you can't lift your foot up, you tend to one of the first things people often notice is the toes of their shoes go through very quickly, or they're tripping. And this helps with that by getting round that nerve and sending An electrical impulse, it detects when you move your hip, sends an impulse to the foot to tell it to come up. And in the early stage of the disease, that can be very useful in improving mobility. In fact, we probably use it more in women than we do in men. And mobility aids, so stopping falling is obviously very important. Having increased mobility is very important. Often people don't want to use mobility aids because obviously people can see them. But actually, if they're helping you get from A to B quicker so that you can get more time once you get to B to do what you want to do and stopping you from falling, they're a good thing. And on the whole, people hold off using them for too long, in my opinion. So sticks, frames, scooters, all very useful, maintaining independence. So that's sort of the muscle side of it. The peripheral nerves, yes, so the problem there is that you can lose sensation, and you need to be very careful with your feet. And again, this is something that's common in other conditions, diabetes, for instance. You get peripheral neuropathy, and you need foot care. And it's similar sort of services here to the foot care. It's using chiropody, making sure you're aware that if it's a hot day, you shouldn't be wearing in bare feet on the tarmac and things. I'm doing rather slower than I should be, aren't I? So chiropody, neuropathic pain. Again, we can use drugs to treat that, pregabalin and gabapentin, again, amitriptyline. Sometimes we need pain clinics for that. And then I'm not going to spend much time on the bladder and the bowel because you got much better talks than me about that yesterday from the nurses from UCH. But for the bladder, it's instability. Again, it's a bit like clonus of the bladder you like. The bladder is contracting when you don't want it to, and that leads to problems. And there are various drugs you can use to try and stop that. And we've talked about adrenal insufficiency in Addison's disease. Steroids is the answer there. Again, this is a common condition. It's rarely due to XALD, but endocrinologists are very used to treating it, and so we'll refer to endocrinologists for doing that. And there are various ways of making sure you've got enough steroids around. Cerebral disease again. So we have always recommended MRIs, particularly in young boys where we know they've got the mutation every 6 months and then every year, because we know if we can pick up those changes we saw on the MRI of cerebral disease, early gadolinium enhancement, then bone marrow transplantation, the earlier you do it, can be effective in slowing down and then stopping the disease after about 6 to 12 months. We didn't used to do it in men, but we do now have a policy that allows us to do bone marrow transplantation in adults if they develop cerebral ALD and we catch it early enough. So we are now doing annual MRIs right through until a time when the risks of, for any patient, the risks of bone marrow transplantation would be worse than the benefits. I'd have to say to date we haven't actually had to bone marrow transplant anyone in the last couple of years, which is good. And we don't do that in women because the cerebral disease is extremely rare, if at all happening in women with this mutation. So, there you are, gadolinium enhancement. So this is the leukodystrophy, and then this is I think this is T1 imaging, but the gadolinium you can then see, we've got an image now that makes this look dark, but that means you can see the gadolinium outside, and that's like the front, so that's what they're looking for when they look for gadolinium enhancement. So that's just a little bit about the eligibility criteria for adults who develop that sort of picture. So MRI confirmed diagnosis. And the main thing of these things, it depends how far advanced the disease is. So this less score is a way of looking at these images and scoring for how much involvement of the brain there is in different areas. And we know, for instance, this would have a high less score. This, unfortunately, would be beyond the point where bone marrow transplantation would be useful. But we need to get the MRI scored, and as long as it's less than 10, and then the expanded disability symptom score is a way of looking at actually how your myelopathy is affecting you. But basically, if you're wheelchair bound or if you're having to catheterize and things, then actually the infectious complications after a bone marrow transplant, the dangers associated with that are going to make it not worthwhile. Because unfortunately, there's a very high infection risk. But as I say, we haven't actually done any of these yet. So what happens if you can't go through that? Well, this is where the Calyx study comes in. So this is the study that Dr. Mehta was talking about yesterday, run by Minarix. This is their drug leriglitazone, which they initially thought might help with adrenomyeloneuropathy, and we had a number of patients in this country who were in that trial. It doesn't help with adrenomyeloneuropathy, and it does have significant side effects. I think it would be fair to say, there we are. Because actually, although you don't necessarily notice it at the time, it causes a fair amount of fluid retention, a fair amount of weight gain, and I have to say, after we stopped the trial, all of our patients felt a lot better when they came off it. But that's for adrenomyeloneuropathy where it wasn't having any effect. If you had cerebral adrenoleukodystrophy and it was having an effect, then that risk, that benefit would be completely different, and you would probably be much happier with those side effects. And there is some evidence, increasing evidence, that this can at least halt and slow down the progression of cerebral ALD. So this, as they say, is a placebo-controlled study. So half the people will get the drug and half the people will get placebo for 18 months. And that's tough because this is a disease that progresses, but there's no way we're going to know whether it works or not unless we include a placebo arm. So this is unfortunately how medical research works. But these are patients who we already know we can't do the hematopoietic stem cell transplant for, so your choice is either nothing or a trial, and the trial, half of that may involve getting nothing for at least 18 months, so 18 months of disease progression, but we might be able to answer the question at the end of the day. So to some extent, it's a rather altruistic thing to do going into clinical trials, because you're not necessarily going to benefit yourself, but we're going to help answer questions for people in the future. So this allows you to have a slightly higher Lois score. You can go up to 12, and it also allows you to have those sort of physical problems that would make bone marrow transplant impossible, but don't actually affect this. We have a site in the UK. We are now doing annual MRIs on our patients anyway, so we would hope that we would pick people up early. And as I say, if we pick anyone up with new gadolinium enhancement, a Lois score less than 12, who can't have an HSCT, then this would be an option. And it's the endpoint is what we call a hard endpoint. It's survival, so it's how many patients are alive at the end of the study. But again, that's what we're trying to achieve here. But they're also looking at other things like the imaging and things. They're halfway through their recruitment. It's taken them 2 or 3 years to get there, so they're nowhere near all the way through yet, but they have opened more centers. And the fact that they now have centers in places like India where there isn't otherwise any treatment will probably mean they'll be able to increase their number of patients. And in the future, this may actually be an option. This has been shown by lots of people. This is the trial design, so you have to either get placebo or leriglitazone for 18 months. If after that 18 months on placebo, you are still all right, then you can switch over to the leriglitazone, and everyone will get leriglitazone. So it's only 18 months of the efficacy. And then, as I say, if by the time the last patient is in, and lots of patients are going to finish the trial by then, they will have a look after 18 months and see whether at that point they can switch everyone across. But basically, you're looking at either 18 months of placebo and then leriglitazone, or being able to have leriglitazone not just for 18 months, you would then continue on leriglitazone afterwards, and this is what they call the long-term extension trial. We've talked about the inclusion criteria, the exclusion criteria. If you've had a previous bone marrow transplantation, or you've had gene therapy, or you've got diabetes, they don't want to do it, because this is a drug, it's a diabetic drug, it wouldn't be safe in that. Those are the endpoints. Right, so more or less on time. What are the take-home messages for the spinal cord disease? There's lots of symptomatic treatment. We like people to stay as mobile as they can for as long as they can, because we think that's good, but use the aids when you need them, because the last thing we want you doing is falling over and breaking things. And as with all symptomatic treatment, actually treating the symptoms before they become a major problem is much better than waiting until they've progressed. It's much more difficult then to control them. So if there are problems, don't be afraid to talk about them. And this came up yesterday with the urinary and bowel people as well. Talk about them, because that's maybe the time to actually be able to do something about them. And I'm going to stop there. Any more questions?
Yeah, if there's any questions, please raise your hand and Ingrid will bring you the microphone. And I'm sure you all know the procedure here. Please do Slido and give us your feedback.
So in one of the other talks, leriglitazone was mentioned, and there was a French study which wasn't placebo-controlled. I forget Yeah. 4 out of 10 people on that apparently improved. Do you have an opinion on that?
I think it looks encouraging, but the problem is that those studies are never controlled, and some people can improve anyway, and we don't really have good natural history data for adults in the same way that we do for boys. So we know that actually in more adults probably it can just arrest. So if you do MRIs, you can see people with MRI changes, but there's no gadolinium enhancement. They stay that way for many years. It can kick off again at some point in the future. So you don't always know if a patient's stable because they're on the drug or they were anyway. And there was a mixture in that of patients who had gadolinium enhancement and patients who didn't. So if you've got gadolinium enhancement and it stops, that's definitely not what we'd expect to be seeing in young boys, maybe more so in adults. We don't really know. But again, for the patients who don't have gadolinium enhancement anyway, I think it's a bit difficult to interpret. So it's definitely encouraging, but if you're the regulatory agencies, they're going to look at that and say, okay, but now you need to do a clinical trial, which is why they're doing the clinical trial. So next they're going to the European Medicines Agency with just that data. Is that going to, and the pediatric data, is that going to change the EMA's mind? They've already done it once, and the EMA said, no, come back with more data. If you want my opinion, I think they're going to say, wait till you've got the results of the clinical trial, but let's wait and see.
So after the clinical trial, do you see the use of liraglutide being extended to more people?
So what they are aiming to do is get it licensed as a treatment for use in cerebral ALD, so gadolinium enhancement with a low score of left, it would be whatever those inclusion criteria is. That then gives you an extra option for treating once it's licensed. We still have what would I think be the gold standard option of bone marrow transplantation. But if it is licensed and there's another choice, we know there are lots of patients who don't get bone marrow transplantation for whatever reason. If they can be put on liraglutide and then clinical experience teaches us over the next years that that's a successful treatment, then you may get a switch in because bone marrow is not trivial. It's not trivial for kids, and it's definitely not trivial for adults. So more choices, but I don't think the results. Clinical trial will get you to licensing. Licensing then gets you to be allowed to use it. And it's not just licensing, there's a funding decision that would have to be made in the NHS as well, because it's not going to be cheap. But then you get the clinical experience, and that builds up over years, and that's what actually changes practice. But at the moment, it's the only option is as part of a clinical trial. Did that make sense? Yes. Okay.
I know years ago, one guy, he died.
So the last one that I'm aware of that we did in the UK, which was a number of years ago now, was successful. And the patients are doing very well, yeah. In an adult, obviously, they're doing them in kids all the time. But as I say, we haven't, it's not that we don't see adults presenting with leukodystrophy, we do. And it's mostly young men in their sort of 20s who they don't know the family history, so nobody knew about it. They haven't had any problems with AMN, or adrenal disease, so it's never been diagnosed. It's being diagnosed for the first time, and by the time they come to clinical notice, because they've developed, normally it's behavioral problems and things, it's far too advanced to be able to do bone marrow transplant. So this is really useful for families where you know the mutation's there, you keep doing the scans, and you pick it up at a point before it's actually affected the brain enough for you to see it. So it's not that the disease doesn't happen, it does. It's just we haven't, in the patients we're monitoring, we haven't picked it up yet. So we haven't done that. But it is important to have those scans.
Slightly off topic, but just because we've got the men in the room, has anyone had any experience of, after diagnosis, looking at life insurance and mortgages and things like that? I've got 2 lads in their 20s. They won't. Yeah? Was it after diagnosis?
It was when I was diagnosed with ALD, but not AMN.
Mm-hmm.
problem is you can't not tell people.
No, that's right.
All insurance is difficult because they use their AI, if you like. You fill in the line and somebody says no. So normally you need to then find specialist brokers who are actually willing to talk to you. And that's where we always say, Alex feels he might know,
Yeah.
but maybe, yeah.
Okay. Thank
But
you.
if you're an insurer, there is a risk. It is undoubtedly going to end up with higher premiums, I'm sure, or with exclusions, because there's definitely risk there.
I would ask Karen if you have questions about that. She'll probably have an answer or no more.
Anything else then? AMN then?
Can you say anything about trauma? And I ask the question in the sense that in my mind there may be sort of anecdotal evidence that if you have some trauma when you have AMN, it can accelerate your decline.
You mean head trauma leading to ALD, or?
Yeah, head trauma, but just generally having a major accident or...
So I think there's probably two things. So there has been and there is anecdotal evidence that head trauma can precipitate cerebral ALD. It's definitely not universal, but there are certainly stories out there. I can see
It's anecdotal.
Tom looking. So I was never very happy when this young man was boxing. But that's, it's anecdotal. But the other thing then is if you have somebody with chronic neurodisability and yes, they have a fall or break a leg or something and then are in bed for a while or severe infection, can that set them back? Definitely. And you may well make some recovery afterwards, but will you get back to where you were beforehand? Possibly not. And I think that's true of, I don't think that's specific to this condition.
The moral is don't have any accidents.
Yeah, try not to. So, I mean, and that comes back to the falling. So yeah, if you're going to be falling, try and make sure you've got the walking aids rather than falling, because breaking a femur or something counts as major trauma.
And don't box.
Well, I think medical advice, lots of people do things that their doctors don't advise them to do. So I'm not going to talk about that.
Well, I hate microphones. Two quick questions. So first one, is there an age limit for the bone marrow transplants? I might have missed it.
Per se, no. But the hematology, it would have to be discussed in what we call a multidisciplinary team meeting, so with the bone marrow transplanters, and they might come up, they might reject on the I don't think it'll be on age per se, because bone marrow transplant is a treatment for lots of hematological malignancies, and increasingly it's been offered to people with multiple myeloma in their 70s, 60s, 70s, 80s, depending on what their general condition is. And in a way, they're much sicker when they get it than otherwise. So no, there's no absolute age limit, but they will look at the degree of spinal cord involvement, mobility, bladder issues and things. That will be more important.
My second question, I don't know if it's a bit basic, but I was wondering about progression. So with the spinal progression, is it something that is like, once it starts, it's like a linear decline, or is it like you're all right for a while and then it pauses, or?
So I don't think it comes over as being linear, because what you notice is step changes and things. Maybe on a biological basis, it is more linear, but that rate will be different in different people, because it undoubtedly, and maybe relates to some extent what the very long chain fatty acids are. But often it's not perceived as being, I've suddenly noticed I've got a problem, and then I'll be using and then suddenly I had to start using a stick, so I perceive that as something else. And it's not, I don't think it's predictable from that point of view either.
So could you have like periods of staying the same, is what I'm kind of...
I think on the staying the same, I think it can appear the same, but actually, if you actually talk to people and think about it yourself, it probably is slightly worse than it was last year when I came. So if you're coming to clinic once a year, you may not have actually noticed during the year that things are any worse, but actually going to come thinking, well, I probably can't go quite as far. But I think you can do things to try and minimize that, which is the sort of physiotherapy side of things and the making sure you get the treatments. But it is progressive, for sure. Yeah, well, I don't think we have a very good way of measuring that. That's the problem.
Is a low-fat diet recommended for people with AMN?
No. Healthy, balanced
Good.
diet, from my point of view. I mean, low-fat diet is a good idea anyway, but not specific. From my point of view, I don't think there's any good evidence that specifically in AMN it makes any difference.
Or taking Lorenzo's oil?
No longer we certainly don't recommend that, and it isn't in the guidelines either for adults with spinal cord disease. And I think it's increasingly used less in children as well now.
And AMN never...
Although Wolfgang Kohler tells us he has some new versions of it that are going to be better, but I don't know what they are. Well, so that was nothing to do with Lorenzo's oil, but yes, there was a Viking trial, phase 1 trial. We were part of that. I have heard nothing from Viking since it finished, which is actually, yeah, extremely bad behavior on their part. We haven't been told who was on placebo, it was a phase 1, so it was a very short period of treatment. No results have been published, and they don't really respond when you ask them. So I wouldn't hold my breath for that. I don't know if anyone knows any more about that. No.
That's exactly where it stands.
Yeah. A lack of communication. So my guess is that means they didn't see what they wanted to see, but maybe they're looking harder.